they tend to be looking at similar kinds of issues. But the way in which they do it is very different. So a country, for example, that has a single payer system is doing it very differently than, for example, a country that has a more fragmented kind of healthcare system. A country like New Zealand, for example, is able to collect similar data across the country from providers of care, from the north and from the south, in rural and as well as urban centers, and collect similar kinds of data to inform quality measurement. Other countries like the United States that are very fragmented can't necessarily collect similar data from the same kinds of providers all across the country. So at a clinical level, measuring the outcomes of patients serially, over time, longitudinally, in a systematic way, what people sometimes call measurement-based care, is a key strategy towards improvement. If you follow people over time, see if they're getting better, and if they're not getting better, using the measurement in an action-oriented way that allows you to make decisions if the patient isn't getting better, to make choices from a menu, if you will, of reasonable options based upon the evidence for intensifying the care, so-called step care models. This measurement-based care system has been shown to improve care on an individual level for patients, and it relies on quality measurement or outcomes measurement as a core feature. What we want to do is develop better measures that document shared accountability for both mental health conditions and general health conditions. So that, and by shared accountability, what I mean is that if you're a primary care provider or a GP, you're equally responsible for the patient who has both diabetes and schizophrenia, for the outcomes related to their diabetes and to their schizophrenia. And if you're a mental health provider or psychiatrist, you're equally responsible as well for the outcomes related to both their schizophrenia and their diabetes. By having this shared accountability, that enforces a greater collaboration. But we have to have measures that measure both of those things more effectively. Several decades ago, a professor at the University of Michigan, Avidis Dhanabedian, developed a framework for how to describe and measure the quality of healthcare generally. He talked about having 3 buckets of quality measures, one being structure, the second being process, the third being outcomes. By structure, he referred to the fact that we need to know the extent to which the health system has the capacity to provide quality care. That is, are there sufficient personnel? Are the facilities set up to provide quality care? Number 2, is quality care actually being provided? That is, are we providing care in a way that is consonant with the care that is expected based upon the research literature? Are we providing both psychopharmacologic and psychosocial services and team-based services that conform with fidelity to the evidence base that exists, showing those treatments that are most effective? Finally, there's the issue of outcomes. Are people actually getting better? Are they getting better not just clinically, but are they also getting better in terms of the kinds of measures that are important to them? Number 1, it's the cost of mental health care. There's greater recognition of the prevalence of people who have mental disorders, its impact on the family, the costs of providing care. Number 2, there's the intersection of mental health care and general health care. People who have comorbid conditions, that is, mental health disorders as well as general health conditions such as diabetes, arthritis, cardiovascular disease, cancer, have much higher costs of their care than people who do not have a comorbid mental health condition. Number 3, there are the hidden costs of mental health care in terms of disability, in terms of presenteeism and absenteeism. This impact is hidden in terms of the healthcare side, but has a huge impact in terms of employers and society at large.